now invite Professor Kirti Singh. I'm not going to say that she doesn't need an introduction because I feel that everyone needs an introduction. And Professor Kirti Singh is the chief of the glaucoma services. She's chief of GNEC Guru Nanak Eye Center. And I've known her since a very, very, very long time. I have seldom seen a person with so much courage of conviction and the wanting to do always, wanting to go ahead in learning and understanding glaucoma and passing on this training to others. Over to you, Dr. Kirti.
Thank you for those kind words, Sagarika. So, we are Indians, and we cannot extrapolate Caucasian data to eyes because glaucoma is very much defined by ethnicity. And we have found in our eyes that lens and iris parameters do redefine surgical options and outcomes in angle closure glaucoma. I have no financial interest to declare. So we do know all these figures by rote, but please remember angle closure glaucoma is responsible for 50% of the global glaucoma blindness, and we as Asians have 3/4 of the PSCG population, and India is pretty much so. Coming from New Delhi, over 4 decades experience in glaucoma clinic, seeing around 4.5 lakh patients per year, we found that angle closure glaucoma in our setup is at least 45 to 50% of our cases, and our patients which are this type come to us with severe visual field defect in 50% and legal blindness in 37%, which is a huge number. And we just wish that it could have been picked up early, but it doesn't happen. So once it is picked up, and these are the type of patients who are going to have all these issues of dependency on an escort and financial status and poor health care, what can we do? So let's look at some established facts. We do know that the topography of the ICG eye, it's a small globe, lens volume is exaggerated, anteriorly positioned, there's angle crowding. This we do know. But the new facts are about the lens vault, that this lens vault is the perpendicular distance between the anterior pole of crystalline lens and the horizontal line joining the two scleral spurs. This increased thickness and bulk of lens anterior to scleral spur plane pushes the peripheral iris against the trabecular meshwork, worsening the angle closure, angle crowding in predisposed eyes. It doesn't happen in every eye, but in the predisposed eye. And these are the studies which say that PSCG vis-a-vis normal and PSCG vis-a-vis POAG, they found that the lens vault to be significantly more, so much so that this term came to be coined as volcano configuration, which was the exaggerated lens vault, which came to be identified as an independent risk factor for angle closure glaucoma. Another established fact is that angle closure glaucoma is signposted very often by these iris signs. We've learned it from the textbook, ectropion, UVA, sphincter atrophy, whirling, and all those things. And these iris clues will tell you that angle closure attack has happened in these eyes. But what is now being found out that there are different mechanism of iris, especially the thick peripheral iris roll in addition to exaggerated lens vault, and the iris is bulky, flaccid, floppy, atrophic. Pupil, of course, is very often non-dilating, so much so that this editorial which I found that the iris behaves like a sponge in angle closure glaucoma by way ahead 10 years down the line. Now it has been identified that there's a pinch region between the posterior iris surface and the anterior lens surface, which is determined by both the lens size and the iris configuration. And these quantitative iris parameters, which OCT has made it possible for us to do, which is iris curve, iris area, iris thickness, are again independently associated with narrow angles after adjusting for age, gender, angle, and anterior chamber depth and axial length. However, there remains a difference of opinion. The Chinese eyes, the Singaporean group said that the iris curve is more, iris thickness at 750 and 200 microns is more, whereas in only one Indian study by Dr. Sehota et al. Said that there is decreased iris thickness, but that study was by UBM. So it is like the Voldemort of glaucoma has done a reductio for the angle and the iris and engorgio for the lens. So let's see how we stand. The Singapore group came up with these studies way back in 1400 eyes, where they said lens vault is highly independently associated with narrow angle closure, and ZAP program customized algorithm was developed by them. Again, that lens vault significantly increases angle closure was again corroborated by the Chinese eyes, and relative lens vault came to be known as a new factor, and this volcano lens configuration came up by both the South Korean group and the Iranian group, which talked about the exaggerated lens vault and the increased iris curvature as being predictive of angle closure. Now, if there's a thick, we always know that plateau iris, the PI doesn't work. But remember now, there's new terminology which has come in, is thick peripheral iris roll, whereas the prominent circumferential folds are seen in 10% of angle closure glaucoma, the PI remains ineffective. And once there is exaggerated lens vault, is there a role of lens extraction? I am not quoting the Eagle study, but this is a different thing altogether. So these 2-3 factors have come up new, and there has been ethnic variation, as the study from Spain showed that whites and Chinese and Hispanics and Africans behave differently. So Hermione came up that, okay, let's see the lens vault, lens thickness, iris curves in eyes of Indian ethnicity, and we did 2 studies of lens parameters in angle closure vis-a-vis open angle, and ACG eyes were 81 and control group were 32A gender matched angle closure open angles which were requiring cataract surgery. And as you can see, the lens vault was significantly different in the angle closure eyes vis-a-vis the open angle glaucoma eyes, whereas lens thickness was different but not so much. This was corroborated by the graphs again, that lens vault and relative lens vault, not lens thickness, was significantly increased in angle closures vis-a-vis open angle, and these are some case vignettes when you can see the lens vault is so much higher in the angle closure vis-a-vis the open angle glaucoma eyes. So much so that now we've started looking for, and what the mind eye starts seeing, what the mind knows, you can actually see that this is a volcano configuration. You don't need the ASOCT to prove it for you. Then the iris curve and iris area, however, were reduced in angle closure eyes, but we do realize that most of these eyes were post peripheral iridotomy, which were not the case in other cases, other studies. So for these patients, our iris curve was less in the angle closure eyes. The other study we did was of the lens parameters in angle closure vis-a-vis control group, which was pure cataract, no glaucoma. And here also we found that the ACG eyes were significantly having a higher lens vault, higher lens thickness vis-a-vis the control group, and again relative lens vault became to be much more significant. The better parameter was relative lens vault in having the better area under curve. See, there are a few case vignettes again of the PACG eyes and the control eyes. You can actually see at a glance how much is the difference in the iris curvature and in the lens vault. The iris curvature, the iris parameters, again on the comparison that the curve, however, in angle closure was not so much as we expected. Again, emphasizing that laser iridotomy, which we did for all the eyes, did flatten out the iris curve. Post-cataract surgery, the decrease in iris curve was noted in angle closure and cataract, which meant that the iris curvature flattened out after PI and after surgery. ACG eyes had a thinner iris at the 750 microns and 2000 microns, and this thinned even further post uneventful cataract surgery in both the groups, both the control groups and the ACG groups. And again, the area was thinner in the angle closure glaucoma eyes vis-a-vis the control groups. Now, this was the previous parameters, that Chinese eyes had a thicker iris and the thicker iris thickness. However, Dr. Sehota's study said that iris thickness was less in angle closure, and we kind of agree with her study that our eyes in India are lesser. So what are the surgical outcomes? How were they different? The surgical outcomes was that the capsular rhexis in ACG patients with such a high lens vault of 0.89 was pretty difficult. The lens is very flaccid, it's like the capsule is all bulging out like a balloon, and it's very difficult in a shallow anterior chamber to do the rhexis. So you have to be very careful at this stage. I would say the most careful at this stage of rhexis in ACG eyes. The other surgical outcome which is different at that ACG eyes had iris chaffing very frequently, and this iris used to have pigment dispersal and floppy iris, and you have to manage the iris very differently in angle closure glaucoma vis-a-vis open angle glaucoma. And we again reiterate what Squiggly said, that iris behaves differently. The other issues was the iris keeps prolapsing out. It's like a floppy iris you have. It's like that, it keeps relapsing out, and we realize after some time to reposit it is pretty much difficult. So what we do is now we just do a surgical PI at that end, reposit the iris, and then carry on with the with the phaco. Just leave the iris wherever it is. Just don't try to keep repositing it. That will cause more trauma. So this billowing iris and the iris prolapse is very common. It's like it just keeps popping out like this genie. Surgical complications, the other ones which we're all familiar with, is the synechulitis, the narrow pupils, and the iris retractors with the bulging lens. So have iris retractors ready, have all the Malyugin rings or whichever ring, because you're going to have these problems. Other thing which we noted new was this iris bleeds, which we see very commonly in ACG eyes, whether it's a TRAB or it's a cataract surgery, which we don't see. So how do we, just 2 slides more. So how is the surgical outcomes redefined? IOP controlled was changed with PACG. It just at 4 months follow-up, the cataract alone caused a 32% reduction, and the requirement of anti-glaucoma medications was there, reduced. Pre-op iris curve was positively correlated with IOP, and the pre-op IT was negatively correlated. So to conclude, lens is bulkier in ACG patients. Relative lens vault is a more sensitive marker. Iris curve and iris thickness in our patients were thinner. Phacoemulsification results in reduction in iris curve. The streep iris configuration reduces from 37 to 13%. AC deepens, and significant index of with the ACG cases in ITC. Positive correlation with pre-op eye curve, negative with the iris thickness, and again with the ITC index. So how do we change it? What have we understood? That iris physiology more than anatomy is different, and lens vault can predict the IOP control. So I finish with this quote from Rudyard Kipling: "East is east and west is west, and never the twain shall meet." And remember, when we are Indians, we are dealing with our eyes. We need to keep these 5 factors in proportion and understanding. Thank you so much.